The following podcast is part of a certified educational activity. Access the entire activity and complete the post-test at peerview.com/EVS 860. Downloadable slides and practice aids are also available.
Hello, I'm Dr. Fernando Revalo, a professor of ophthalmology from the Johns Hopkins Bayview Medical Center and the Wilmer Eye Institute at the Johns Hopkins University School of Medicine in Baltimore, Maryland. Welcome to this case-based activity entitled Seeing the Importance of Timely Recognition and Treatment of Diabetic Retinopathy and Diabetic Macular Edema. Joining me today is Dr. Mandeep Brar from the Division of Endocrinology, Diabetes and Metabolism in the Abrazo Health Network and Cigna Health Insurance in Phoenix, Arizona. As part of this activity, we will discuss different aspects of a patient case to review current evidence-based recommendations for screening patients suspected of having diabetic retinopathy to encourage timely diagnosis, referral, and or treatment, and to improve visual outcomes in patients with diabetes. Let's begin by looking at the scope of diabetic retinopathy in patients with diabetes. Recognizing the scope of diabetes and diabetic retinopathy is of most importance. It is a huge healthcare issue. Globally, it is estimated that more than 600 million people will be affected by diabetes by 2045. With the increasing prevalence of diabetes, more people are at risk for diabetic retinopathy development, and greater resources are required to make the diagnosis and treat this condition. Individuals with diabetes have high rates of many types of vision-threatening eye disease, including cataracts, diabetic retinopathy, glaucoma, macular degeneration, and corneal disease, and many of them have a significant impact on quality of life. There are common screening tools for diabetic retinopathy, including direct ophthalmoscopy, visual acuity testing, indirect ophthalmoscopy, visual fields, including computerized visual fields, and fundus photography. Many of these screening tools are inadequate for making the diagnosis of diabetic retinopathy or diabetic macular edema, but if there is any abnormality or failure on any of these tests, it is important to refer to an ophthalmologist with diabetic retinopathy expertise. There are many barriers to diabetic retinopathy screening, some of them related to healthcare professionals, including unclear roles and responsibilities, possibly limited time for office visits, and lack of specialty providers to refer to, in addition to inability to access records outside of their own healthcare network. Other barriers related to patients may include difficulty differentiating screening tests from comprehensive exams, lack of symptoms from diabetic retinopathy, and limited understanding of diabetic retinopathy and diabetic macular edema exam findings. There are also facilitators of diabetic retinopathy screening. From the healthcare point of view, it would be ideal to have an integrated team-based care. In addition, electronic healthcare records-based best practice alerts are important, as well as a robust referral network. From the patient's point of view, it is ideal to have patient education and self-management support programs, telephone calls, reminder letters, and again, educational brochures. In the remaining program segments, you will have the opportunity to select different case variables and decision points that will lead you to an exploration regarding the rationale for timely recognition and treatment of patients with or suspected of having diabetic retinopathy. Let's get started by learning some details about our patient, Matteo. Matteo is a 49-year-old landscaper with a history of type 2 diabetes for 4 years. He presents to his primary care provider for his not so annual visit. He shares that he has been experiencing progressive blurring vision over the past few months, and he has not required corrective lenses, but he is recently having trouble reading street signs. He denies any flashes or floaters, diplopia, or eye discomfort.
You have selected referral to specialty care for suspected diabetic retinopathy as the decision point, with the complicating variables of a high deductible health plan with limited access to specialty care. The prevalence of diabetic retinopathy and diabetic macular edema varies with race and ethnicity, as shown in this slide. People with a Hispanic or African American background have a greater propensity for both diabetic retinopathy and diabetic macular edema compared to Caucasians. Symptoms alone are a poor indicator of diabetic retinopathy. Early symptoms really include very little, maybe some fluctuating visual acuity, but often this is a reason why patients don't get their eye exam in a timely manner. They wait until they have symptoms that occur later: floaters, flashes of light, decreasing vision, blurred vision. And these are all symptoms of a much more severe retinal damage occurring from diabetic retinopathy. Diabetic retinopathy can be divided into two classifications. One, non-proliferative diabetic retinopathy, and the second, proliferative diabetic retinopathy. NPDR, or non-proliferative diabetic retinopathy, is further subdivided into mild, moderate, and severe. During both of these types of diabetic retinopathy, macular edema can occur. And as the patient progresses through greater damage, greater vision loss also occurs. Health insurance coverage may increase the adherence to annual eye exams that are recommended. A study suggested in 2016 that 56% of people with insurance coverage got their eye exam in the past 12 months, versus only 29% who did not have health coverage insurance. And if a patient had health insurance that was a high deductible plan and had the additional health savings account, they were more likely to get their eye exam. So these are some things that maybe we can have our practice talk to our patients about. Another important barrier to consider is access to retina specialists. As you can see in this graph, there are a greater number of optometrists and general ophthalmologists throughout the United States, but retina specialists are limited to 2,100 in the nation and are in focal locations around the country. So consideration for teleophthalmology in primary care practices through insurance, annual checkups, as well as in endocrinology practices may be something that would be of use to identifying these patients, to then encourage them to see the retina specialist. Returning back to our patient, Mateo. As you recall, he had limited access to specialty care, a high deductible insurance plan, and therefore was referred to an optometrist in town. The optometrist diagnosed bilateral astigmatism, prescribed glasses, identified some difficult to interpret bilateral findings on two-field fundus photography, and referred the patient to a retina specialist in a nearby city. He was also allowed to pay the optometrist visit in installments, and the insurance coordinator discussed HSA for the patient to use next year. When Mateo saw the retina specialist, he reviewed the primary care provider's records, which included a hemoglobin A1C that was controlled at 6.7%, normal blood pressure, and cholesterol. He performed a comprehensive dilated eye exam with a slit lamp and an OCT, and that demonstrated non-center involved diabetic macular edema diagnosed bilaterally. Treatment options presented to Mateo included wait and see, focal laser photocoagulation, intravitreal anti-VEGF injections. For follow-up, Mateo agreed to return in 4 to 6 weeks, and the retina specialist's practice manager sent clinic notes to the primary care provider.
You have selected referral to a specialty eye care for suspected diabetic retinopathy as the decision point, with the complicating variables of white coat syndrome and fearfulness of injections. Visual function has many dimensions. It's not only visual acuity, but it includes reading acuity, peripheral vision, contrast sensitivity, dark adaptation, and photostress recovery. Vision-related functional burdens occur even in patients with diabetes, but without retinopathy. Some of these burdens include reading, problems with close-up work, seeing steps, seeing objects on a shelf, problems with peripheral vision, and driving. According to a study, individuals with diabetes and no retinopathy had about as much trouble with this visual task as individuals with diabetic retinopathy. This is a flow chart from the International Council of Ophthalmology guidelines from 2018 on screening for diabetic retinopathy. And basically, if patients have a good visual acuity, a routine examination can be performed yearly. If there is loss of vision 20/40 or worse, and very mild or moderate non-proliferative diabetic retinopathy, and non-urgent referral needs to be performed with refraction and complete assessment. If there is severe non-proliferative diabetic retinopathy or complications of diabetic retinopathy, including diabetic macular edema or proliferative diabetic retinopathy, an urgent referral is necessary. There are some diagnostic tests for diabetic retinopathy that most ophthalmologists will be able to perform in their offices, including dilator of slit lamp and indirect ophthalmoscopy that help to make the diagnosis of diabetic retinopathy, OCT or optical coherence tomography, which makes the definitive diagnosis of diabetic macular edema, and fluorescein angiography, which is a dye test that also helps make the diagnosis of diabetic macular edema, non-proliferative diabetic retinopathy, and proliferative diabetic retinopathy. Back to our patient, Mateo, he has limited access to a specialty care with a high deductible insurance plan. The PCP referral emphasizes that Mateo has a white coat syndrome and a fearfulness of injections. The ophthalmologist explains to Mateo what to expect from the comprehensive eye exam and reassures that there is no injections associated to this visit. A complete examination is performed with dilated slit lamp evaluation, indirect ophthalmoscopy, OCT, and visual fields. No abnormalities were found in the retina. Cornea abnormalities were consistent with dry eye with a visual acuity of 20/30. Diabetes increases the risk of corneal disease, especially on a patient like Mateo, who is frequently outdoors. He was recommended to start eye drops and UV blocking sunglasses and a follow-up appointment in 12 weeks for another ophthalmology evaluation.
You have selected referral to specialty eye care for suspected diabetic retinopathy as the decision point, with the complicating variables of a poor diet and poor glycemic control. Risk factors associated with incidence and/or progression of diabetic retinopathy include the following: longer duration of disease, chronic hyperglycemia or elevated hemoglobin A1C, uncontrolled blood pressure, and associated nephropathy. Another factor that can impact diabetic retinopathy is uncontrolled dyslipidemia. The risk of developing retinopathy in people with diabetes depends on their blood glucose control, as this slide shows. As the patient has a higher A1C baseline, it takes less years for them to develop diabetic retinopathy. And the longer they have poor metabolic control or an elevated A1C, once again, they have a higher risk of developing diabetic retinopathy. Recommended eye examinations for patients with diabetes are in line between the American Diabetes Association and the American Association of Ophthalmology. Depending on the type of diabetes, the patient can have their eye exam at different times post-diagnosis. If your patient has type 1 diabetes, they should have their first eye exam about 5 years after they were initially diagnosed, and after that, yearly. If the patient has type 2 diabetes, they should get an eye exam at the time in which they're diagnosed, and after that, they should have an eye exam yearly. And now back to our patient, Matteo. His primary care provider referred him to an ophthalmologist, and during that ophthalmology visit, it was noted that his hemoglobin A1C was elevated at 10%. The ophthalmologist performed a dilated slit lamp examination and OCT, which demonstrated center-involved diabetic macular edema in the right eye, and a mild cataract was noted in the left eye. Matteo is really surprised by these findings. He didn't know diabetes could cause eye problems. Treatment options include removal of the cataract and intravitreal anti-VEGF injections for the diabetic macular edema. Matteo decides to have the cataract removed right away, but wants to defer a decision about diabetic macular edema treatment, hoping he can improve his hemoglobin A1C, and this will help his eye improve as well. The ophthalmologist nurse sets up a follow-up appointment with Matteo's primary care provider to discuss what we call the ABCs of diabetes management: hemoglobin A1C reduction, blood pressure control, and cholesterol improvement. He also will spend time with a certified diabetes educator to address lifestyle and behavioral changes that he can apply to his daily routine to impact his blood glucose and cholesterol. The ophthalmologist will perform a cataract extraction of the left eye, and there'll be a follow-up visit to look at the right eye and see the progression or stabilization of the diabetic macular edema.
You have selected ophthalmologist confirmed diagnosis of diabetic retinopathy as the decision point, with the complicating variables of high deductible insurance plan and limited access to specialty eye care. What is optical coherence tomography, or OCT, and how is it used in the diagnosis of diabetic macular edema? OCT is a non-invasive imaging technology that measures retinal thickness with very high precision and visualizes the retina in cross sections. So we can see the different layers of the retina, and we can see if there is presence of fluid within the retinal layers. So diabetic macular edema can be very subtle on ophthalmoscopy, but it's clearly evident on OCT. We can see cystoid macular edema, the presence of subretinal fluid, and on the retina map, we can see an elevation of the central macular thickness that is represented in red. In terms of treatment for diabetic retinopathy, one of the most common therapies nowadays is intravitreal injections. We can give anti-VEGF agents or corticosteroid implants for diabetic retinopathy and diabetic macular edema. Intravitreal injections are a sterile procedure given with topical anesthesia, and a very small needle, 30-gauge needle, is utilized to give the injection and usually is performed in the office. Anti-VEGF agents available include aflibercept, bevacizumab, and ranibizumab, and they are given monthly. There can be a very low risk of increase on intraocular pressure or development of cataract. However, with corticosteroids, the duration is longer. We can use dexamethasone or fluocinolone acetonide. Also for diabetic macular edema, the risk of cataracts and glaucoma is higher. Infectious endophthalmitis, retinal detachment, and sometimes vitreous hemorrhage can occur after intravitreal injections, but they are rare. Some studies have demonstrated already the effectivity of anti-VEGF intravitreal injections, including the DRCR-NET Protocol T, showing here in the graphs a significant reduction on central macular thickness after anti-VEGF therapy. Changes in visual acuity after a series of anti-VEGF intravitreal injections has been also demonstrated in Protocol T from the DRCR-NET. And we can see that in patients with good visual acuity or poor visual acuity defined as 20/50 or worse, there is significant improvement in visual acuity with these injections. Another option is to give corticosteroid implant injections, which work very well on patients that are pseudophakic with persistent diabetic macular edema. The dexamethasone implant has been demonstrated that works very well with injections every 3 to 4 months. And the fluocinolone implant in chronic diabetic macular edema lasts for up to 3 years. Again, these implants can cause cataracts. That's why they work especially well on patients that are already pseudophakic or had cataract surgery with intraocular lens implantation. So back to our case, Mateo has limited access to specialty care, and he is first evaluated by an optometrist that did a slit lamp dilated eye examination that determines that there are hard exudates near the fovea in both eyes, which suggests the presence of diabetic macular edema. He is referred to one of the clinics where patients with limited access to specialty eye care can be seen in the university, and a complete ophthalmic examination is performed with a slit lamp evaluation, indirect ophthalmoscopy, OCT, and ultra-wide field fundus photography and fluorescein angiography. A diagnosis of center-involved diabetic macular edema in both eyes is performed. There is no proliferation or vitreous hemorrhage, and the treatment options include anti-VEGF therapy, focal laser photocoagulation, and possibly a corticosteroid implant. The clinic provides all services on an income-based sliding scale. Mateo decides to go for anti-VEGF treatment. He's given then appointments monthly for 6 months to get the injections and then PRN treatment. You have selected ophthalmologist confirmed diagnosis of diabetic retinopathy as the decision point with the complicating variables of white coat syndrome and fearfulness of injections. What is ultra-wide field imaging and how is it used in the diagnosis of proliferative diabetic retinopathy? In the center circles on the photographs, you can see that with a conventional camera, there is very limited view of the retina. With the ultra-wide field imaging, we can see up to the periphery of the retina, about 210 degrees of the retina, and we are able to make a diagnosis of peripheral disease such as neovascularization elsewhere in the retina or vitreous hemorrhage that may need treatment with anti-VEGF injections, or if there is significant hemorrhage, a postplantar vitrectomy. Initial management recommendations for patients with diabetes have been outlined by the American Academy of Ophthalmology. If there is normal or minimal diabetic retinopathy, an evaluation every year is fine. If there is some mild non-proliferative diabetic retinopathy, still a yearly evaluation is fine as long as there are no complications of diabetic retinopathy, such as diabetic macular edema that may lead to more frequent visits. In cases of moderate or severe non-proliferative diabetic retinopathy or proliferative diabetic retinopathy, then visits have to be performed more frequently. Every 4 months is what I usually recommend, but it can be anywhere from 3 to 6 months. And if there is diabetic macular edema or proliferative diabetic retinopathy, patients may need monthly visits to be treated with anti-VEGF injections or laser photocoagulation. Laser photocoagulation techniques include panretinal laser photocoagulation that is used basically for proliferative diabetic retinopathy. That in several studies have shown that it reduces the risk of severe visual acuity loss, but also reduces peripheral vision and contrast sensitivity. Focal laser photocoagulation is used for diabetic macular edema. Nowadays, diabetic macular edema that is not involving the central part of the fovea and can improve visual acuity as well. Panretinal photocoagulation can affect many aspects of vision. There is studies that show subnormal performance in peripheral vision, contrast sensitivity, visual acuity, dark adaptation, and reading acuity after patients receive panretinal photocoagulation. There are some studies now demonstrating that there are changes in visual acuity associated to panretinal photocoagulation as compared to intravitreal anti-VEGF agents for proliferative diabetic retinopathy. When we compare these two treatments in Protocol S or Clarity, these studies demonstrated that patients treated with anti-VEGF injections had better visual acuity than patients treated with panretinal photocoagulation. On this table, you can see the side effects and complications of treatments for diabetic retinopathy. Many of the treatments of laser photocoagulation include scotomas and laser scars that can expand, as well as difficulties with pupillary dilatation. Intravitreal injections also can have some side effects, including infections, vitreous hemorrhage, and retinal detachment, but these are much more rare. It is important setting patients' expectations for the management of diabetic retinopathy and diabetic macular edema. Patients may discontinue treatment because they feel the treatment is just not working. And it's important for them to know that anti-VEGF therapy is the best treatment nowadays and first line for diabetic macular edema. However, visual acuity may improve only in about 40% of patients that receive anti-VEGF therapy, meaning that more than 50% of patients may not improve, but will maintain visual acuity, and that is a significant benefit. They may need laser photocoagulation to maintain that visual acuity, and let's keep in mind that temporary worsening of visual acuity may occur after any of the treatments that we utilize. Back to our patient, Mateo. He sets an appointment with an ophthalmologist. At the ophthalmology visit, it was noted that he had a hemoglobin A1C of 6.7%. It's been more than a year since Mateo had his last comprehensive eye exam. And Mateo explains the difficulties that he had coming to an ophthalmology visit, including fearfulness of injections and a white coat syndrome. The ophthalmologist performs a comprehensive eye exam, including dilated slit lamp examination, indirect ophthalmoscopy, OCT, and visual fields. And proliferative diabetic retinopathy was found in both eyes with a visual acuity of 20/50. So retinal neovascularization was demonstrated. And the ophthalmologist gives Mateo the options of anti-VEGF therapy, panretinal photocoagulation or PRP, or a combination of the two. And the ophthalmologist discusses benefits, limitations, and follow-up schedule. Mateo decides to have a panretinal photocoagulation to minimize the amount of time that he will need to take off work. And insurance coordinator schedules Mateo for a PRP and follow-up in 2 weeks for 2 weekly PRP sessions.
You've selected ophthalmologist-confirmed diagnosis of diabetic retinopathy as the decision point, with the complicating variables of a poor diet and poor glycemic control. The American Diabetes Association strongly supports the use of shared decision-making as a vital and effective way to improve diabetes management, outcomes, and quality of life. Shared decision-making is simply aligning your goals as the primary care physician to the goals of the patient to achieve outcomes of better blood glucose control, compliance with medications, behavioral changes, and lifestyle management. It's important to do this at every visit you have with a patient with diabetes. At each visit, it's important to consider what factors may be impacting the treatment plan that was given at the previous visit. And if anything wasn't followed, you should question why that was in a very non-judgmental way and try to help the patient understand why your treatment goals are important for prevention of complications. It's also important to understand if the patient is not getting their eye exam, what is creating a barrier to their eye exam. If the patient says, well, my vision is fine, it's important to explain to the patient that often visual signs and symptoms don't occur until diabetic retinopathy has progressed to a more severe state. And a yearly eye exam will get a good look at the back of the eye and allow for monitoring to occur. In a busy clinic, it's important to find time for shared decision-making. And it really starts with asking questions that have no assumptions, being supportive, and not accidentally being judgmental of the patient's situation. Attempting to give them undivided attention and providing time for reflection for the patient. Often, that can be set up before the patient actually comes into the exam room. Using your medical assistants to ask questions to the patient while they're doing the vitals, such as, what are you doing for diet and exercise? Or have you had your eye exam recently? And if not, what were those barriers? You can use your medical assistant to share those insights with you before you walk into the exam room to help drive a conversation that will lead to proper outcomes and filling in gaps in care for that individual. Individuals who have become blind cite many obstacles that they encountered along the road of their worsening vision. Some of the main themes included readiness for seeking eye care, so their awareness of an association of eye disease that can occur silently was absent. The patients may not have prioritized their need for an eye exam and focused on other complications that were more obvious to them, or they were frankly in denial. Another theme included trusting their providers, and that can only come with time and open, non-judgmental communication with your patients. Access to care, availability of specific eye care providers, cost of the visits, or understanding under which benefit, medical insurance or vision insurance, the different eye providers, optometry, ophthalmology, and specialized ophthalmologists were covered. There are severe consequences of inadvertent treatment interruptions in patients that are receiving anti-VEGF treatment. Several studies have shown that patients who develop diabetic retinopathy with diabetic macular edema and begin treatment with anti-VEGF agents, if they interrupt their therapy or they have what we call non-compliance for various reasons, financial hardship, fear, inability to make their appointments on time, inability to miss their work, or inability to have somebody drive them to their visits and stay with them, led to worsening in their eye disease over time. Medication accessibility can influence treatment selection, adherence, and blood glucose control. As the year changes, the patient's formulary and insurance may also change. There are tools available in which you can look up which drugs are preferred on a patient's formulary, what pharmacies may provide a better retail pricing for those same medications. And there are other programs available that can improve the affordability of the patient's diabetes medications in order to maintain compliance and allow for a lower out-of-pocket cost for that patient. Returning back to our patient, Mateo, he reluctantly set up an appointment with an ophthalmologist and brings copies of his medical records. At the ophthalmologist visit, the medical assistant notices that Mateo's hemoglobin A1C is elevated and he hasn't had many primary care visits in the last year. The ophthalmologist performs a comprehensive eye examination, including dilated slit lamp examination, indirect ophthalmoscopy, OCT, visual fields, and near vision. Proliferative diabetic retinopathy is noted bilaterally, as well as old laser scars. There's vitreous hemorrhage and neovascularization in the right eye. On an ultra-wide field fundus photography, vitreous hemorrhage and neovascularization are found in the extreme periphery of the right eye. Mateo is very upset that something else has gone wrong with his eyes. The ophthalmologist sees that the patient's overwhelmed and asks Mateo if he would like to discuss his treatment options, as well as his whole healthcare plan with the practice's nurse practitioner. The nurse practitioner spends some time with Mateo and tentatively diagnoses him with depression as well. Nurse practitioner offers suggestions, including more frequent follow-ups with a primary care provider to discuss how to better control hemoglobin A1C. Treatment choices include anti-VEGF injections or augmentation PRP. For follow-up, the ophthalmologist calls the primary care provider to have a detailed discussion that the patient was overwhelmed, the diabetes is not well controlled at all, and this is significantly impacting the patient's eyes. There may also be a concurrent diagnosis of depression. The appointment schedule gives Mateo an appointment for a session of PRP augmentation in the right eye in 2 weeks.
In this activity, we have learned that a comprehensive annual eye exam by an eye specialist is essential for patients with diabetes because they are at an increased risk of many different types of eye disease. Diabetic retinopathy, including diabetic macular edema, may not have noticeable symptoms until retinal damage is extensive. Primary care providers can help patients reduce their risk of developing diabetic retinopathy or diabetic macular edema by controlling the ABCs, A1C, blood pressure, and cholesterol of diabetes. Prompt diagnosis and treatment can preserve vision. Accordingly, primary care providers may need to assist patients in accessing specialty eye care, finding an ophthalmologist who can diagnose and treat diabetic eye disease, and/or reminding them to follow up with eye specialists. Additionally, retina specialists can offer patients effective treatments for diabetic retinopathy and diabetic macular edema, including laser photocoagulation, intravitreal corticosteroid implants, and intravitreal anti-VEGF injections. Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/EVS860. This activity is supported by an educational grant from Regeneron Pharmaceuticals. This activity has been jointly provided by Johns Hopkins University School of Medicine and PVI, Peerview Institute for Medical Education. The activity is also co-provided by the Institute for Johns Hopkins Nursing.